Welcome her here, Dr. Dinah Bitner. She's a board certified OB-GYN here in Michigan, in Grand Rapids, and a certified menopause practitioner. That's a big deal. If you are in that phase of life and you are having difficulty, it would benefit you to find a certified menopause practitioner who has dedicated her career to transforming how we care for women in midlife and menopause. With over 28 years of clinical experience, she is nationally recognized for her expertise in helping women understand the hormonal changes of perimenopause and menopause, and for guiding them with practical, that's important, personalized, very important strategies to feel their best. Dr. Bitner is an assistant professor at Michigan State University, just down the street, and co-founder and chief medical officer of True Women's Health. Okay, that is in Grand Rapids, and they're a MESSA provider. She is also the author of I Want to Age Like That: Healthy Aging Through Midlife and Menopause, and the creator of the Sex Deck. Okay, a unique tool that opens the door to real conversations about sexual health. And we need to talk, right? Her mission is to ensure every woman knows what's happening in her body and how to take charge of it without shame, confusion, or silence. Welcome, Dr. Bitner.
Thank you for having me. This is really exciting and a honor to be with you guys today. I can't wait to get into this. I want to keep this pretty informal, and so if there's chat, if there's questions coming in during, I'm okay with that. Rhonda knows that as well. We'll both be watching the chat box, and Rhonda, if you see something, feel free to stop me, and we'll go ahead. So, Rhonda, I
Okay,
can't thank you enough. Yeah.
you're still in presentation. You need to go in presentation mode. You're still in the notes mode.
Oh, I apologize. Thank you
No
very much.
problem. It's happened to
There we go.
everybody.
How's
Thank
that?
you. Yep, you got it.
Okay, good. So again, feel free, and I think when I'm in presentation mode, I maybe can't see the chat. So again, please feel free to interrupt and share things. But my goal today is that you all have an idea about what's coming. I always like to say this is not our mother's menopause. We don't have to suffer like women did in the past. We get to use this time to do even more if we want to do. Back in the day, women died at 50, and now we get to live to 100. So let's make these next 50 years count. And for so many years, this hasn't been something that people talk about. I ask a lot of women, do you know when your mom had menopause? And they're like, I don't so much, because she never talked about it. Or she had a hysterectomy and she said it was fine. People would suffer in silence. We know that 10% of women leave the workforce during menopause. I just saw a patient the other day who, because of poor sleep, memory, she had brain fog, she felt like she just wasn't focused. She, actually a teacher, she decided that that wasn't what she could do anymore, and she couldn't keep up and do the best job, so she stopped, and she really misses it and has regret. And so I really want to look at menopause as an opportunity for us to reconnect with what we want, what we're looking for to do in our life, how we can be connected to our passion, we can keep our curiosity. So menopause is an opportunity. It's a positive thing. It doesn't have to be a negative thing anymore. So I kind of want to use a case study as a way to kind of think about this. Hopefully this is helpful. And this is just kind of a generalized, how people present to see us here at True. Patty was 51. She had had 2 babies. She came in for her annual exam and she was in early menopause. And I asked her, the first thing was, what is difficult? And, often the tears start because this is really personal stuff, and it really can affect how we feel and how we show up every day in our lives. She had weight gain. She was tired all the time. She had anxiety where she never had anxiety before. She had night sweats where she'd wake up in the night and some nights she'd be just warm, some nights she'd just be in a pool of sweat. And she had low sex drive. It really was in a good relationship, loved her husband. They had had a good sex life for years, but she just didn't want to be intimate. She was an elementary school principal. She had no period for 10 months. So she's either in late perimenopause or early menopause. We'll talk about that. She had irregular and heavy periods for years. In the last 3 years, she'd been gaining 3 3 to 5 to 8 pounds a year. She was tired at night, so she wasn't working out. She was feeling guilty if she took time for herself. So she was just really in a place where my body's changing and it doesn't make sense. And how can you help me? So many people then think like, really, menopause is an opportunity. This just is a period of time that stinks. It really stinks. And unfortunately, a lot of women will go to their provider, and many providers are not trained in menopause. And so a lot of people are told, yeah, this is a time you just got to kind of buck it up and get through it. You just, it will pass, just deal with it. And so this can be really frustrating, but again, it really can be an opportunity. So these are really common mysteries. We're going to go through some of these symptoms. These are common mysteries. And as you heard, I'm an OBGYN by training. And how I got into all of this was when I was about 42, my patients were aging with me. They started asking me questions I couldn't answer, like, why am I gaining weight? My jeans aren't fitting. My summer clothes aren't fitting. You're trying to get back in the bathing suit to be outside, and I don't want to put my bathing suit on. For some people, it's sleeping. They can't sleep well. They're getting night sweats. For some people, again, it's libido. It's, I don't want to be sexually active. It hurts. All those things. So those are the mysteries that I couldn't answer. I could deliver a baby, I can do a surgery, right? But I couldn't answer this stuff. And I thought, I really need to know more about this. And so I'm going to go to a medical meeting around this. And I was blown away about what is known, how much research has been done, but it wasn't being communicated well. So I really decided I need to learn more. I need to dive in. And now it's become my passion and I just love it. So these are the mysteries. And I think about perimenopause as the perfect storm. It's where the symptoms of perimenopause and menopause are really affecting quality of life. I can't sleep, so the last thing I'm going to do is get on the treadmill at 5 o'clock in the morning before work, right? I didn't sleep well, so now I'm craving cookies. And when there's, cupcakes in the break room at lunch, I'm going to have not one, but maybe two because I'm craving it and I want to stay awake. Maybe it's mood stuff. I'm irritable. Patients will tell me I don't even like myself, right? Or I want to divorce myself. I don't know how he puts up with me. Or I'm yelling at my kids. I'm barely keeping it together at work. So at home I lose it. So all these symptoms. And then the physiology of perimenopause and menopause affect us. So right before this, right, you were talking to a physical therapist. What happens in menopause is our joints get stiff. We have joint pain. So those are physiological changes where inflammation increases and those joints get stiff and tight. Our cholesterol goes up. Our insulin resistance goes up. So think of menopause as a pre-diabetic state. It really increases the risk of central obesity, craving carbs, blood sugars going up, which then also increases our risk for heart disease, diabetes, obesity, dementia. So perimenopause is this time where it can be really tough. It can also be the opportunity to reconnect and make a difference. There's a study done that has been really helpful over the years called the SWAN study. So the SWAN study stands for Study of Women Across the Nation. And this was done at 9 study sites across the country. The study is now about 15 years old. It looked at women of color, Hispanic, of Asian descent, and white to see how do these women experience the perimenopause transition differently. So it really looked at these populations of women. It wasn't an interventional study, so they didn't do things to these women or offer things to these women. They just watched them. So whether or not they took hormones or not, how do they sleep? How do they develop heart disease? And we learned a lot of really interesting things. For example, women of color tend to experience hot flashes that are worse and earlier, and they last longer, and they last with more intensity longer. So really important to look at that difference. Women of Asian descent don't tend to have hot flashes, night sweats. They tend to have more mood disturbance. So again, that helps me as a provider that when I see a patient, it doesn't mean that's where we stop, but I might, ask a bit more about those things or really make sure we're flushing those things out. And we learned a lot about, again, the power of treatment, for example, with menopause hormone therapy or with support for insulin resistance, how this can impact a woman's life over her lifetime and keep her doing the things she wants to do. So happy to talk about the SWAN study. So again, I just want to leave you guys today. We got lots more time, but it is possible. Like, I'm 58, I'm just getting started. I feel great. Yes, I'm empowered with lots of information. I want you guys to know as much as I do. I want you to know more about your bodies than a provider would. So, what is menopause? We lose autopilot. We can't drive the car anymore. We lose steering, and we don't want it to end in a fiery crash, right? We want to take advantage of this opportunity and all this great knowledge. So what I'd like to do now is go into a bit of teaching about, like, what is it? Like, why are these things happening to your body? And so first of all, let's talk about the phases. Number one, reproductive. Reproductive phase is when your periods are regular. And late reproductive phase is when your periods are still regular, but you might start having some symptoms. So for those of you in the audience who are a bit younger, just know that sometimes even when you're in your early 40s, you could start to have symptoms right before a period. Like, let's say, a night sweat 2 nights before your period. You could have worsening menstrual migraines. You could have more mood disturbance. You could have just more bloaty and you just don't feel well. And so that can happen. A lot of times women will go to their provider and say, I think I'm in perimenopause. And their doc will say, well, do you have regular periods? And they're like, well, yeah. And they'll often feel like they get patted on the head and say, oh, honey, you're too young for that. You're actually not, because the ovary starts to change with how it works, and you actually can have symptoms. Perimenopause means if you have a uterus and you don't have an IUD, you will still have periods, but they're very irregular. So early perimenopause is when your periods change by more than 7 days, at least once, but then it might click back to normal for a while, and then it goes irregular again, and then it goes normal again. So perimenopause is when things are really just starting to change. Late perimenopause is when you've gone without a period for more than 60 days, and then you might click back to normal again. But the change has happened. The number of functional eggs in your ovary is starting to drop. Your hormones are changing more rapidly. And you might have 3 days of the cycle where you made 3 eggs and your estrogen level is super high, and your breasts are swollen, and you're crying at the drop of a hat. You think everyone's talking about you, really paranoid. Like, a lot of women will get very symptomatic that 3 to 4 days of ovulation, and then after that, the estrogen level crashes. Period happens early, and it's really heavy. So that's late perimenopause. And the most common thing around this is that it's a roller coaster and it's changing all the time. Menopause is when you haven't had a period for more than 12 months. Or let's say you've had your ovaries removed because of surgery, or for women, for example, who suffer from breast cancer and have to have treatment with chemotherapy, a lot of times that will stop the ovaries from working, and that will create a menopause from chemotherapy, or some patients with radiation for other types of cancers. So those are things that can happen along the way. I'm just going to check the chat box. Sounds like me.
Let me help you. It says you specifically mentioned irregularity. If one does not have an IUD, does this also apply if someone uses a different form birth control, such as
As the pill. Yes, ma'am. So the birth control pill is oral synthetic estrogen and oral synthetic progesterone. And what it does is it tells your brain, hey, you don't need to make the ovary make an egg because the hormones are already here. But what it does is the estrogen containing pill can really make your estrogen levels low and even. So a woman I saw yesterday, she's been on the pill for 15, 20 years. Her estrogen level is so low that I worry about her bones, but also she's got really low libido. She's got some depression and anxiety that's consistent. Her skin isn't great. Her mood isn't great. So it really, I think it's impacting a lot of her health because her estrogen level is so low. So yeah, it can really change things. And sometimes what we'll do is say, hey, if you want to try off the pill, take your ovaries out for a spin for a couple years and really, like, understand how you'd feel without that pill. If you still need family planning, birth control, the IUD is an amazing option. It can make sure you don't have periods and control if that's been an issue for you in the past, but it can help you just enjoy your ovaries for a bit before they go into menopause. So I hope that answers the question.
She said, thank you. There's another
Okay.
question in there. It says, does
Please.
diet low in sugar help with menopause symptoms?
It can, as long as you maintain your blood sugars at a healthy. So let's say you're not having like any carbs, not even healthy vegetable carbs or not even carbs with high fiber. If your blood sugars are too low, that can actually cause night sweats. So let's say someone's eating a low carb diet and they're, at dinner time, they're having maybe just some protein and maybe a salad, like a salad with chicken on it. Blood sugar kind of drifts down. When your blood sugar drops really low in the middle of the night, you get an adrenaline response, and that adrenaline response can make you have a hot flash. That's how the thermostat works, and we're going to talk about that in a minute. So too low is not great either. And a lot of times here at True, we'll use continuous glucose monitors to help people monitor their blood sugars to see what foods are making my sugar spike, or why is it dropping so low, and then why am I feeling those symptoms? So we'll get into that a little bit more. So let's talk about symptoms. So, let me go back, sorry. Okay, symptom circle. So this is something that, I don't know, Rhonda, if you want to put the link in the sidebar, but I invented the symptom circle that you can access on our website. The symptom circle, I invented this about 15 years ago because I needed, number one, for me to understand this as I taught it, but also for women to take this and say, these symptoms are real, you're not crazy, and what can you do to make them better or worse? And so as we go around this, for example, hot flashes can be worse if your blood sugar is too high, if your blood sugar is too low. If you've gained extra weight, it's like wearing a sweater you can't take off, and a lot of people get hot, and it increases the risk of hot flashes. If you're dehydrated, you're going to have worse hot flashes. So it's really important to know. So as we go around the symptom circle, you're able to kind of get a sense of all these. And these symptoms are the most common symptoms of menopause, and we're going to go into each one of them and talk about why. As a menopause specialist, I feel that my number one job is, again, to help you understand why these symptoms are happening. So then you can say, okay, I've tried the basics. Now maybe I do want to understand if there's any treatment options to help me feel better. And again, then I would want you to know those options and know what feels right for you. So to have informed consent. I really believe that your care should not be limited by the education level of the provider you're seeing. So it's to seek out a menopause provider, is to make sure that you know the good websites, know the sites to say, hey, I want to be offered this option. Why didn't you offer that to me? So let's talk about night sweats. Night sweats and hot flashes happen because your thermostat is not working so well when your estrogen drops. So I want you to think about, in your brain, you have a thermostat, just like the thermostat in your classroom, in your home. You set the thermostat, let's say at 70. Let's say the sun comes streaming in and now the room is warmer. What happens? The thermostat tells the body to turn on the air conditioning. Just like the thermostat in the room will tell the system to turn on the air. Your thermostat works the same way. We humans are not turtles. We can control our own temperature within reason. So if we get too hot, we get flushed, and that releases the heat. If we get too cold, we shiver, right? So when everything is perfect and our estrogen's good, our blood sugar's good, our range is about 4 degrees. So we can get 2 degrees warmer or 2 degrees colder and nothing happens. If we get more than 2 degrees warmer, so we're at 90 or 100.6, our air conditioning will come on. When we lose estrogen, now our comfort zone is 0.4 degrees. We can get 0.2 degrees warmer. If we get more than that, we are flashing. And so that happens where we're flashing, we're sweating, and then a lot of times, because our comfort zone is so narrow, we overcool with sweating, and now we're shivering, and now we get too hot again. So women in menopause will say, I'm always too hot or I'm always too cold. We've learned a lot about the physiology or the actions of this thermostat with the advent of these new drugs. You might have seen Veoza advertised at the Super Bowl. Veoza is a non-hormonal drug that's used to treat hot flashes. And because of the discovery of this drug, it's what's called an NKT. It's a type of drug that stops the air conditioning from going off. It actually helps block those same receptors that estrogen blocks when you have estrogen. So again, we've learned a lot more about this. So we also know that the air conditioning can be triggered Again, if your blood sugar is way too high, if it's way too low, if you're stressed out, if you've had alcohol, certain drugs can trigger it. So it's those, like sometimes like an ADD drug will trigger maybe a hot flash. So it's really making sure that you understand what is my trigger. And if the only trigger is estrogen being low, then maybe you might opt for, let's say, menopause hormone therapy. So that's why hot flash and night sweat works. A lot of women will ask me, why is it happening when I get in bed? You know, everything's good, I feel fine, I get in bed, I put on my covers, and whoosh, I get a flash. That's because, again, just that little bit of extra warmth from those covers, you're tired, you know, all the things. Sometimes just going to bed cold can really help you get a better night's sleep. But let's say your bed partner rolls closer, or the dog or the cat gets on the bed, you are just now insulated, core temperature goes up, excuse me, and now you're flashing. Oh, Nicole, yes, we're accepting new patients. And also, we have a great website, but we can talk about that. Again, our mission at True is to reach as many women as possible. So even if it's all of our free content, we really want to reach more people, so you all know this. Let's talk about irregular periods. Irregular periods happen because I want you to think about the lining of the uterus like your lawn. So your estrogen is like fertilizer, progesterone is like weed killer. So as the hormones change from your ovary, it can make the uterus lining grow and then not fall off if you don't ovulate. So that flow of the hormones is what controls those periods. So people bleed because either the lining is too thick, the lining is too thin, or it's really spotty and irregular. So what are danger signs? Of course, if you bleed every 2 weeks, we want to know about that. If you have a period that lasts more than 10 days, we want to know about that. If you have a flow that's heavy where you're changing a product more than twice an hour, or you're passing big clots, could you have really thick lining? And things that we will get concerned about in the perimenopause is, do you have other risk factors, let's say for uterine cancer? Do you have diabetes? Do you have obesity? Are you taking estrogen without progesterone? Some of the compounded medications, which we don't prescribe because I don't believe they're safe enough to feel good about them. But a lot of the compounded medications will have estrogen, but not adequate progesterone. So lots of fertilizer, no weed killer. So it's really important to think about that if you choose some of those therapies. Again, make sure you see someone who knows what they're doing. Disturbed sleep. We talk about something called WASO. It's now a thing called waking after sleep onset. And we know that people who wake in the middle of the night and can't get back to sleep often may be caused by a hot flash that you might not perceive, or a low blood sugar. People who have WASO for long periods of time, years, have an increased risk of dementia. So is it that it's the low estrogen causing dementia? Is it that the poor sleep causes dementia? We think it's probably a bit of both. So it's really important to recognize this and get help, figure this out. You gotta sleep, people. Like, sleep is so important for healthy weight, for healthy blood sugars, to reduce your risk of chronic disease. Sleep is really important. What I'll make is, if I'd like to share a quick suggestion. If you do wake at 2 a.m., number one, say hello to all your sisters out in the world who are also waking up at 2 a.m. But then what I want you to do is right away tell yourself, I got this. If you get stressed about the fact that you woke up at 2 a.m. and you look at the clock, that stress just feeds the fire. A lot of times you'll have a worse hot flash or night sweat, or you get into fight or flight, and now you can't break that cycle and you can't go back to sleep. So tell yourself, I got this. And then get out of bed right away. Yes, please get out of bed right away. Go pee, drink some water, sit in a spot that's your Zen spot. I have a chair in my room I'll sit in if that's the case. Sit in the chair, just breathe through your nose, open your eyes, stare at a spot, and think about what you're so grateful for you can't stand it. That gratitude will get you out of flight or fight, and it will help you break that cycle. Go back to bed, but here's another trick. Keep your eyes open. When we close our eyes, we see pictures. So open your eyes. It's dark. I'm in bed. It's sleepy time. I'm going to go to sleep. If you lay there and you can't get back to sleep, get up, do it again, repeat the cycle. It really works. But again, it's also figuring out, why did you wake up in the first place? Weight changes. This is probably the most common reason people come to True or seek help at a menopause clinic anywhere in the country. It's because people will say, I'm doing the same things, I'm eating the same, I'm working out the same, but I'm gaining weight. What is wrong? What else can I do? And we know that number one, as your estrogen drops, you become more insulin resistant. So, for example, if you have diabetes in pregnancy, this especially applies to you. If you have a family history of obesity or diabetes, also really applies to you. But this is everybody. This is someone who starts out at 90 pounds and now they're gaining weight in their belly. This is someone who already is carrying extra weight. Even more so, it's going to be an issue. So what we know is that the factors that affect this are poor sleep, again, your family history, your muscle mass. If you are starting perimenopause with a lower muscle mass, it is time to get on that. Muscle mass probably impacts longevity more than anything. It impacts our blood sugar control, and it's just huge in terms of being able to respond to these other challenges. The activity level that makes a difference. A lot of women will come in and they're like, I'm doing HIIT workouts and I'm doing the Fit Body Boot Camp and all the things. The problem with those HIIT workouts is it's anaerobic, right? So your heart rate's really high, you're pushing really hard. The only time we burn fat is when we're in zone 2. Zone 2 is that zone where you're breathy, you're sweaty, but you can still talk. That's zone 2 out of 5 zones of exercise. So if you're doing 20 minutes 3 times a week of zone 2, that's where your mitochondria are more efficient. You're making energy, you're burning fat. So it's really the stress. You don't have to do a HIIT workout to lose weight. Stress and cortisol. People talk about the cortisol belly and people sell books talking about the cortisol belly. That just means that if you are stressed when you eat, so let's say you're a teacher, you're grabbing a quick lunch at your planning break and you've got kids outside and you're behind on checking all of your worlds, like when you're stressed, or if you're stressed when you eat, that food has no choice but to go to your fat. And if at the same time you're eating, let's say, a white flour tortilla or some white tortilla, oh, Deja, I love your comment. Like if you're eating low fiber carbs and not much protein at that meal and you're stressed, it's going to belly fat. Belly fat's sitting there like a vacuum cleaner, ready to suck up that sugar. So it's just really important that if that's your environment and you're not going to change it, I want you to change your inside, right? I want you to stop, think about something you're so grateful for, taste the food, make sure you're doing protein first and your carbs are high fiber. We have a book that you can get on our site called True Nourishment. And in the back, there's a fiber. Well, that's the protein one, but there's a fiber sheet that talks about what foods have more fiber. So for example, more avocado, more berries, Ezekiel English muffin bread, whole wheat fiber tortillas, a Triscuit instead of a chip or a tortilla chip. So really think about having protein first, fiber, and if you have a treat, you have a cookie, don't beat yourself up, go for a walk. Go for a walk before your blood sugar spikes and it goes into your belly fat. So those 3 tricks can help a lot. So it is really difficult and yeah, Deja, it really piles up. Like it's just so easy. Just like we talked about Patty in our case study, that weight just gained up. Talking about urogenital symptoms, we call this genital urinary syndrome of menopause. It can also happen in early perimenopause, and this is where as your estrogen levels start to fall, you can have more vaginal dryness, more arousal difficulties where it's hard to get aroused even if you think you want to have sex. Lady Town is not paying attention. You might have more frequent bladder infections, and you might have a higher risk of what we call lichen sclerosis. And Melissa, I'll get to your question. But that lichen sclerosis is where you have itchy skin that tears really easy on the outside of your vagina. It can cause pain if it's treated. Lady Town, yep, Lady Town. If it can be treated, but long-term not treated, it can increase the risk of skin cancer down in Lady Town. So we want to make sure that you're not suffering from lichen. I bet 50% of people have it. So if you look at your bottom and you see where you've got little crack lines or it's itchy or it hurts or it's really tender, the skin is really sticky, make sure you see a provider who knows about lichen. Super common. I'm going to go back up to Melissa's question. Do you have suggestions for those of us who have had success in a GLP-1 but can no longer afford it because their insurance? So, it's a big deal. Here at True, we have one nurse, or it's her whole job just to help people deal with prior authorizations and all the things. Number one, the cool thing is that the companies are making these meds way more affordable. So if you have a provider who has access and can teach you how to access the drugs through Eli Lilly Direct or through Novo, they have a lot more savings plans. And again, they're just making them a lot more affordable. We know that the compounded medications for GLP-1s are just not safe. So I would really caution those of you who would be maybe looking for an alternative. Number one, they're about the same price as what you can get the real drugs for. The other thing is that the compounded GLP-1s are illegal after yesterday, May 1st. We'll see how well that's enforced, but those drugs are just not safe. They can make your body make antibodies against your real chemicals. So again, I would caution you, don't use the compounded drugs. You deserve the real ones. And again, to see a provider who knows how to help you get those drugs. The other thing is to really know that low estrogen triggers the liver to set you into fat storage mode. So if at the same time you're using a GLP-1, you've done well on it, it's making sure you're treating the other reasons. We have patients who are on GLP-1s and on metformin to treat their insulin resistance. They're building muscle. We're working on sleep and hormones and all the things. So it's again, just more than just that. Carrie says, can you give me an example of a compounded drug? Compounded drugs for the GLP-1s are just that. They'll say, this is a GLP-1, just like Mounjaro or Zepbound, but actually they're compounded. They're not the exact drug. Compounded drugs for hormones, they're named all different things. For example, I saw a lady who is transitioning off what's called Biest. So it's a compounded cream with 2 different estrogens in it. Again, just be cautioned whenever. So if I prescribe a hormone, your insurance will pay for it. You can get it at the pharmacy, right? It's not something I'm selling out of my office. So just be careful when providers are making money from drugs they sell. Red flag. And what Rhonda said, they come from compounding pharmacies. Thanks, Rhonda. So again, a lot of these meds are available and safe. So in terms of urogenital symptoms, let's say you're someone who has low estrogen and vaginal symptoms. And let's say for some reason you don't want to take menopause hormone therapy, or you've had breast cancer and it wouldn't be safe for you. What I'd recommend is potentially using estrogen in the vagina. Estrogen in the vagina does not go into the blood when you use the proper medicine. So there's different FDA approved medications that are very safe and they stay in the vagina, they don't go in the blood. 90% of women have these symptoms. And for example, these symptoms can lead to chronic bladder infections, chronic kidney infections, and in little ladies in the nursing home, what's a common cause of death? Infection, sepsis from bladder infections that probably wouldn't have happened if they had had vaginal estrogen. So again, really super important. If vaginal estrogen isn't something that you're comfortable with, there's another product called Interosa, which is FDA approved vaginal DHEA. It's called Prasterone or Interosa, and it works just as well as estrogen in the vagina every day. And again, reduces the risk of all these things. So just again, know that there's lots of options and you are different than your friend and you might want a different option than your friend. Sex drive. There's so many components to sex drive. Most OBGYNs, you've probably experienced this, are not comfortable talking about sex. Probably only 10% of OBGYNs will ever bring up sex. Understand, Cheryl, yours is dead, but it doesn't have to be if you don't want it to be. So the thing with sex drive is that there's 27 reasons for low desire. I invented the sex deck, which you can get on the website, because I didn't know how to talk about sex. I wasn't trained in it. And I would go to these meetings and lectures and hear all these amazing experts who are now good friends talk about why people have low sex drive. I thought, I'm not going to remember all this. And how do I talk about it with a patient in the office? And then how does she take it home to talk to her partner about this? So the sex deck. These issues about sexual desire are all broken down by psychological reasons, by physical reasons, let's say pain, let's say chronic back pain, let's say medication side effects, or interpersonal. I had a patient once who said, I just have no sex drive. And I'm like, well, do you like your partner? Well, they're like, well, no, I don't like him. He's mean to my kids. he doesn't take care of himself. He has big nose hairs. Like, I'm not even attracted to him. Like, I'm like, well, why would you want to get naked with someone you don't even like? So again, it's all the reasons. And in terms of, hormonally, when a woman is in menopause and her estrogen's low, her testosterone is also likely low. And so we know that these hormones have a big impact on what's called spontaneous desire, where you just think about sex. Then there's responsive desire, where you might think about sex, but you don't want to do it. Like your partner might say, hey, and you're like, thought about sex earlier today, but I just don't feel like it. So why is that? Maybe it's because you're tired, right? So a quickie in the morning sometimes can be the best thing because then it's out of the way. It was good, but now I don't have to think about it at 9 o'clock at night. So again, I think the more that we all talk about this, the more that we make it a normal conversation. And what the sex deck can do is it can give you language, right? Everything is about having language. How can you talk about this? Sometimes taking the sex deck home is like, okay, this is a thing. It's not my fault, it's not your fault. It's a thing. There's things. Let's say you go through the sex deck and nothing applies, or some things apply, but you're working on them. Some women actually have what's called hypoactive sexual desire disorder, HSDD. There are now medications, and Deja, I'll get to that, but there are medications now to treat HSDD. So for example, we have two medications. One's called Addyi. It's an FDA-approved drug that helps increase spontaneous desire in the brain. It's a very distant cousin of medications like Lexapro or Prozac. It's a very distant cousin. We know that it doesn't give too much serotonin, but gives a little bit, and it can be just enough to increase spontaneous desire. We also have a medication available called Vyleesi. Vyleesi, aka the horny shot. So the horny shot is a shot you give yourself. 45 minutes later, you're chasing your partner around the room. It lasts for 12 hours, so do be aware that you might want to have sex for 12 hours, so maybe save it for vacation. But that horny shot really works well. We just can't use it in someone with uncontrolled hypertension. We recommend you keep it at 8 shots a month, so you don't maybe raise your blood pressure, and it can cause nausea. So researchers thought, well, women won't want to use it because it's a shot. Oh, they do. And people won't want to use it because it causes nausea. Oh, they do. We just prescribe it with a little anti-nausea medicine. It's all good. So again, there are options. You don't have to suffer. And Cheryl, if you want that drive to come back, it's possible. Yeah, so nausea actually is reasonable, and it mostly happens on the first time. Deja said, any advice on how to encourage male partners to get their testosterone checked? It all comes to what do they want, right? So for a lot of guys, if testosterone is dropping and that decreases their spontaneous desire, it might even make it harder for them to want to go get it checked because they're like, I don't really want it anyways, so why get my testosterone level checked? But again, that's part of the whole cause. And so it would be really to be curious and ask those questions about what do you want? Do you want to be, connected in an intimate way? When you were having sex and could have an erection, did you feel younger? Did you feel more vital? Did you feel more sassy? Did you feel more confident? Did you like the muscle mass that comes with good tea? So if the testosterone level is checked, there's good options for men. We also check testosterone levels in women, and we follow the international guidelines and actually can treat low testosterone in women. So it's an option, and we use FDA-approved testosterone that's for men in women at 1/10 the dose, because we don't have an FDA-approved testosterone for women right now. That's a whole nother conversation. We're hopefully working on it, but right now this is what we do to keep women safe. And we replace levels to get them closer to your normal level for a woman, not level of a teenage boy that can happen with a pellet. So I caution you, do not use the pellets. They are not safe. So that's a whole sidebar. But in terms of, men, the other thing is that there's a really good book that I highly recommend called 8 Dates. 8 Dates is the 8 critical conversations to have with your partner to reconnect. I just got married in May, so still feeling like a newlywed. We went through that book before we got married to make sure our values, we were on the same page with things like money, intimacy, family, dreams and hopes, physical activity, right? So it just sort of helps you reconnect with your partner on your values and what you want. And if you get to the intimacy chapter, there's some really good language. Each person does their own homework. You come together, ask each other all these open-ended questions, and it really can be helpful. And there are therapists called Gottman therapists that really know how to work with this book and other books by the same authors. So again, highly recommend it. Moving on, we could talk about sex for a whole nother hour. And Rhonda, I'm not looking at time, so please tell me if I need to wrap up or what's going on.
Yeah.
Mood changes. Estrogen affects brain chemicals. So as women go through changes, postpartum, estrogen drops. Right before a period, estrogen drops. In the perimenopause, menopause, estrogen drops, and that can affect our brain chemicals. So I think about brain chemicals like money in the bank. And when we have more brain chemicals, we can have more joy. We feel like doing things that we like to do. But when estrogen goes low, we go through those brain chemicals quicker, and we might have what's called anhedonia. We just don't like to do things that we normally like to do. It's really good to have a tell, like my tell is I don't like to make dinner. I mean, I like to make dinner. If I don't like to make dinner, that tells me something's up. I'm stressed. I'm going through my brain chemicals too quick, all the things. So it's really important to have a tell, like I said, but when those brain chemicals are low, it can really be a sign that, wow, I'm being affected by my perimenopause. If you're not sleeping, you're not going to make brain chemicals. And genetically, some people just don't make brain chemicals. Deja, that's funny. But those brain chemicals, so sometimes it can help to take a medication with brain chemicals in it, like let's say a Lexapro or a Prostiq. These medicines can be really helpful for postpartum depression, PMDD, which is PMS on steroids, or perimenopause or postmenopause mood disturbance. Estrogen can also help. Sleeping can also help. Again, looking at why you have these symptoms are really important. And then thinking about what stresses in your life are not resolved. So again, this is a whole conversation, but it's really important to know that it's not your fault. These are things that happen because of a chemical change in your body. And there are definitely things that can be due to, we can do to resolve. It's also like if you have a lot more stressors in your life, which is so common in the midlife, right? We have parents getting older, we have kids doing stuff, we might have a spouse doing stuff like not getting his testosterone checked. So then what happens is that we're dealing with all this extra stress, but it's harder to deal with it when our brain chemicals are off. All the patients that come to me and say, I used to be the person people come to, now I got nothing. I got nothing even for myself, right? So again, really important to validate this, and you don't have to suffer. Lifestyle affects symptoms. So we have something we call the seeds, which we'll go into, but we look at the 7 essential elements of daily success. So these symptoms are, again, these lifestyle habits are really important. So of course, we know women who smoke cigarettes, they have a much higher risk of early menopause, and their menopause is worse in terms of hot flashes and night sweats. We know that sugar can cause symptoms, all the things that we've talked about. This is the other thing that I just don't want you guys to leave without knowing about and just being really clear with is that menopause is the most dramatic risk factor for heart disease, dementia, diabetes, obesity, osteoporosis. It really makes a difference. And so again, if hormones aren't something you're going to choose to take, then you got to make sure what are your risks in all these other areas if you don't want, let's say, heart disease. I saw a patient today and I said, what are you worried about? She said, my dad died of a heart attack at 42. I don't want to die of a heart attack at 42. Okay, let's talk about that. Let's get a calcium score of your heart. Let's look at your LDL cholesterol. Let's look at your lipo little a. Let's really do a deep dive and understand what is your risk of heart disease, and then how will these body changes affect that, and how can we mitigate those risks if you don't want a heart attack. If you're okay with that, let's not look, but that's a big deal. Shauna, what about the use of SSRI in perimenopause? Again, SSRI is like Prostiq, Paxil, Prozac, Lexapro. They can make a huge difference because by putting brain chemicals back in the system, again, it can just level you out so you can cope better. And then again, we could add in, is estrogen right for you at this time? But SSRIs are a big deal, and you might need it for a couple of years and then you go off it and you don't need it anymore. It just depends on your genetics and your brain chemicals. Canadian pharmacies, there are a couple drugs that actually we can't get in the US. There's one called Femostan that we get from Canada. I have to write a letter to the border agent and they come across. So it just depends, Tina, on what med. So certain meds, yes. Certain meds, again, the one med I know about, yes. In terms of the GLP-1s, I don't know about that. So again, it's legit. It's just can be hard to get them across the border. Who knows how tariffs affect, but we won't go there. Having said that, what I want you to think about is it is possible. There's the steps. Number one, what do you want? So I just inferred a story of a patient who I asked her, what do you want? I don't want to have a heart attack. I have women who say, I'm taking care of my mom with memory issues and was just diagnosed with dementia. I so don't want that because I don't want my kids to have to see me like this. All right, let's figure out what are your risks. Do we do genetics and figure out if you have the genetics that put you at risk for Alzheimer's? Do we do a brain scan and look for the early signs of dementia? You know, we figure out what do you want and then where are you now? So again, this patient this morning, what is your risk for heart disease? She doesn't want a heart attack. We now know from looking at all those factors, we've looked at them in the past, we know that her risk is pretty low. So how can she maintain that low risk? What are the solutions? So she chooses to take menopause hormone therapy. She chooses to exercise. She eats pretty well. She has some barriers. She travels a lot for work. So we've got to sort of think about how can we mitigate. On our platform, we have meal plans. We have a trainer that you can access wherever you are from and look at the exercises for the week. So again, it's thinking about what do you use, what's in your toolbox. These are the seeds, the self-care basics, the 7 essential elements of daily success. The number one thing that is important is water. It really surprises people how important water is. I hear from a lot of teachers, I can't drink water because I'm in the classroom. I get it, but then you got to be smart about it. If you start drinking water, let's say on the weekend, and you get your level up to 80 net ounces, that means water minus alcohol minus coffee is net. The goal is 80 ounces net. So if like you're like me, I have 2 cups of coffee a day, I'm going to need 2 extra glasses of water. So when you have enough water, it will help reduce hot flashes, gives you more energy, all the things. So water is critical. Sleep is huge. We've talked about that. Exercise, it's all 3. It's stretching, it's aerobic, it's strength training, and it sounds like you've got a great resource at MESSA to use to get all that in order. Macronutrients, that would be protein, fat, and carbs. We got to have all 3. It's to know which ones are best for me and always go for the high fiber. Micronutrients, vitamin D is number 1. Got to get your vitamin D. 2,000 units a day is a good number. But it's also looking at, are you getting your, especially if you're on a GLP-1, are you getting all those micronutrients like zinc? You know, when our patients are on those meds, we're checking those vitamin levels every 6 months. It's really important. Are you getting enough fiber? Not just in food, but do you need a supplement if you're not getting it? And meter breathing and gratitude is really important for sleep, like we talked about. Coffee and alcohol, caffeine. Yeah, and sorry, any caffeinated beverage. I'm biased toward coffee, but yeah, any caffeinated beverage. If Diet Coke's your drink of choice or a caffeinated energy drink or whatever, definitely make sure you're doing your net. So I'm looking at other questions. MESSA covers. Exactly. A lot of women will use their HSA for the membership. And again, please know that I wish that everyone had care like what you can get at True. Unfortunately, to have an office where we can spend an hour with each patient for that first visit, we're available 24/7, just insurance wouldn't pay for that. So unfortunately, we have to have the membership fee. But what I'm hoping is that we get enough data, we get enough about how this model improves healthcare for women overall, then more insurance companies will cover care like this. The other thing is that I really want to reach as many women as possible. It is possible to come on to our platform and just, we're not your doctor, but you can at least get the information. There's videos, there's modules, there's teaching modules. You can get the workbook, the book, and you can use these maybe even with your provider wherever you are to help then raise their boat, raise your boat by sharing this information. Again, we want to reach as many women as possible, and using this platform can be something, I don't know, it's $10 a month or something, where you can have access to the information here at True. I know we wanted to make sure and get to hormones a little bit. I know, Cheryl. And again, I feel bad for that. I feel apologetic. But, you know, we do have patients at True who do have more money than God. We have people who are scraping their pennies together to come. They might come for a year, get everything in order, and then they go back to the regular provider. So again, it's one of those things to think about with your budget. What do you want to do? But I understand the challenges. Menopause hormone therapy, again, what are these hormones? These are the messengers that go around in your body, you know, starting from your ovaries. But when your ovaries run out of eggs, that's menopause, then you don't have those hormones anymore. Nicole, this is a good question. Does having stage 4 endometriosis affect symptoms? It doesn't affect symptoms so much, other than it could maybe enhance pelvic pain if you have scar tissue in your pelvis. It also might affect how we treat with hormones in terms of making sure we get enough progesterone or weed killer for those cells that are in your pelvis, let's say, that are very estrogen sensitive. Fertilizer would make them grow. So we have to make sure that we're balancing out the estrogen with adequate progesterone. And it can just, yeah, it's a big deal. And there's a lot of history I'm sure you've had with ovulation. So hopefully that helps. So these hormones, again, making sure. So what are the sources? So estrogen comes from your ovary. This just talks about the a, a progression of an egg that can't even talk, that goes through your cycles, and how the little cells around the baby egg are what make your estrogen and your progesterone. And testosterone is made by those little cells in between the eggs. Does having your tubes tied make a difference? Julie, what some people notice is that menopause could happen maybe a little earlier when you have your tubes tied, because maybe the blood's been interrupted, the blood supply's been interrupted to your ovary. But if you look at a large group of women who have had their tubes tied, it doesn't tend to change a whole lot. So I'd say no. So I guess short answer is no, probably not really. The other place that estrogen can come from are fat cells. So if people carry a lot of their weight in their belly, that belly fat stores pre-hormones, and it can increase estrogen, not in the sense of improving hot flashes, but for example, it can increase a woman's risk of uterine cancer. So we want to make sure that we're being careful about if she takes estrogen, she's got enough progesterone to balance that out. Deja, are there risks specific to women who have been taking oral birth control their entire life? Risk specific. So again, we get a little concerned with long-term synthetic estrogen. It's not great for bone. So I'd want to make sure we're looking at a very early bone density to make sure we get a baseline and understand that. Also, if your estrogen's been low a long time, that can affect your bones. The other thing is that the synthetic progesterone that's in the birth control pill, we don't have data that it will increase your risk of breast cancer, but progesterone that's synthetic can increase your breast density, which we know is a risk factor for breast cancer. So if your breasts are very dense and you have other risk factors for breast cancer, then perhaps having high-risk screening, including an MRI every other year or every year, having an extra breast exam, having an extra ultrasound, just really making sure you understand your risk factors for that. I hear you for the cramping and nausea, but again, there's other things for that. Not to say, oh, here's a, you know, it's not like I'm trying to push therapeutics, but yet we have other ways to treat that if you choose to go off the pill. Just saying, there's a lot that's been developed since you started it. Oh, sorry, I went forward. So estrogen, it's FDA approved for hot flashes, for vaginal dryness, prevention of osteoporosis, and to protect the lining of your uterus. But off-label, there's not been enough. There's been a lot of research around these things that we're treating, but they haven't gone to the FDA to get approval because it's very expensive, and we just don't need that. We just need to know it's safe. We know that estrogen and menopause hormone therapy can help with mood changes, can help with libido, with sleep, with skin and hair. I don't support necessarily putting estrogen on your skin, which is a big Instagram trend right now. There's no data to support that, but it's probably not going to hurt you, so whatever. It helps insulin resistance. We know that people even already with type 2 diabetes, if they choose to take menopause hormone therapy, it can actually improve their sugar control and maybe even help reduce their A1C over time. It definitely helps with muscle mass. If two women are in menopause, one's taking hormones, the other is not, they're working out the same. The one on estrogen is going to build muscle mass quicker. We know that for a fact. Estrogen, I can't say if you take this, you will be less likely that you're not going to have a heart attack, but we know that it does reduce risk factors for heart attack. It reduces insulin resistance. It reduces the plaque being all gunky in your heart vessel wall. So it likely does decrease the risk of a heart attack. We know that it can likely reduce the risk of those white matter changes in your brain that can lead to stroke and dementia. So again, there's a lot of data that just keeps growing that it is good for, that it can be very good for you. Women who are low risk for complications, less than 10 years from menopause, healthy weight, low LDL, calcium score less than 400. There's a heart test that is very important to look at your risk for heart disease called a coronary artery calcium score. So a CAC is the term. Insurance will not pay for this. Hopefully someday all insurances will pay for this for screening. If your score is less than 400, you probably don't have blockage and hormones would be safe for you. If your score is over 400, it's likely that you have blockage. And how I think about this, I'm on Fox 17 every week, and I talked about this a couple weeks ago. There should be no such thing as a surprise heart attack because we now have the technology to understand if you're at risk for a heart attack. So, for example, a woman who is thin works out and then has a heart attack, and everyone's like, oh my God, I can't believe it. Well, if we had looked with a calcium score, we would have known. So again, this is something all women deserve to have. If your blood sugar is less than 5.7, if you're doing your healthy lifestyle, again, estrogen is a really potential average option. The average cost of a CAC is about $200. Corewell does it here in town for right around 200. There's a cardiology office in town that does it for 120. So these are things that can be ordered by your provider and done at a reasonable cost. Not to scoff at $200, but for a lifetime risk, to know your risk, it can be really valuable. If it's normal, then we do it every 5 years. I had my first one 5 years ago, and I'm having my repeat next week. So it's something that I want to stay on top of and understand my risk. Vaginal estrogen, again, there's 3 products. There's a ring that we don't use much anymore. There's cream, there's an insert. Again, it's very effective. And on the package insert, it will say in a black box, estrogen causes stroke, breast cancer, all the things. We know that those data are not true for most women and certainly not applicable to vaginal estrogen. So if you look at that package insert, please disregard that black box warning. And here are some non-hormone options. So again, we recommend Paxil is FDA approved for hot flashes. It's sold under a name called Brisdel, which is half-dose Paxil. Lexapro is very effective for hot flashes. Effexor and Wellbutrin can help. We know that SERMs, these are medications for bone loss, can also reduce the risk of hot flashes like Aspina, Duavie, and Evista. For low sexual desire or HSDD, we use Addy or Vyleesi. Veoza we use for hot flashes that's non-hormonal, and elazinitant is coming out by Bayer here in July. So there are lots of options that are on the horizon. So I could keep talking, but I thought this would be a good place to stop, and here's some discussion topics, but happy to answer questions. Again, I'm not looking at the time, so Rhonda, I want to be respectful of your agenda and just let me know how I can help.
Any questions? This is a great place to end. I think you have given us a plethora of very, very valuable and helpful information. I think everyone on the platform would agree, and they are expressing that in the chat. I'm just overwhelmed, Dr. Bitner, such great information. I'm happy. I was telling a part of our team here, I'm so glad the sessions I do are aligned with a lot of what you're saying,
That's
especially
awesome.
like that water one.
Yes.
I think that simple can be very important to our energy and our mindset and how we feel. But if you can check out the chat, they love this. I
I'm
love this.
looking.
Now,
Thank you.
tell me real quick, we chatted about it on Monday. You're doing a campaign throughout Michigan. Would
Yes,
the
thank you.
attendance of the people here be important for that or helpful?
It would be awesome. So Governor Whitmer wants Michigan to be a state that leads in legislation for coverage of menopause medications and menopause support and more providers being educated and becoming certified menopause providers. And so Governor Whitmer has asked the Michigan Women's Commission, which, oh my gosh, I had no idea that the Michigan Women's Commission existed, and the women on it are just amazing from all areas of Michigan. So the commission is going from town to town to talk about menopause and get people's feedback about what is needed. We were in East Lansing a couple weeks ago. I'm in Detroit this next Monday. It's on the Michigan Women's Commission. It's on my Instagram feed. It's on my True Women's Health feed, on where to be. We're going to be in Grand Rapids, I believe, in early June. So look for those dates. Again, it's on the True platform because we really want to promote this to gather more information from the communities of what people need. We'll be in the UP at some point. We're going all over, and I've been honored to be asked to lead and open up these sessions and then be there to answer questions. So again, honored to be involved. Halle Berry came to kick off the event at the governor's mansion a couple months ago. So on my LinkedIn page, you can see that I have a picture of myself with Governor and Halle Berry, who is amazing and even more beautiful in person. And she's actually very normal. So it's cool. Halle Berry is doing a big push for menopause education, and she started a company that has menopause coaches. So we talked briefly. I would love to think someday we could collaborate. So we'll see what happens there. Oh, thanks, Rhonda,
Wonderful.
for that link. Appreciate that.
Absolutely. I wanted to share what you shared with me, but I couldn't find it, so put that up there real quick.
Awesome.
Thank you so much. Thank you so much. And if people are interested in being a patient, I put the website there.
Oh, thank you.
They can seek that out, and definitely go to her website for all the different resources she has. And we have her right here in Michigan. So, and really Grand Rapids is not that far. I'm in Lansing, not that far. But also you can go to menopause.org and locate a provider that is a menopause certified practitioner as well. I learned that from Dr. Bitner on.
That's right. Perfect. And a lot of us, us included, we do telehealth as well. So it's just, to get access to providers, sometimes you have to look a little harder. And again, hopefully it'll be more and more available. And again, we have a ton of free content. So check out our YouTube channel, our website, our Facebook page. Again, we want to reach as many women as possible with this information. So please check it out and take advantage of it.